Eric, City, and Ndu, the usual guys every day, and we're joined by somebody new who is going to help us have a conversation. Now, on the 24th of March in 1882, something big happened. The bacterium that causes TB was discovered. And now, since that point, people have gotten to understand what tuberculosis is all about. Since then, we have not had it. Now, the WHO has designated the 24th of March every year as World TB Day to raise awareness about TB, to talk about the progress efforts that are being made at national level, at global level, national level, at community level on addressing issues of TB. Joining us this morning is somebody from the Ministry of Health. Maina is the sub-county TB coordinator for Embakasi in Nairobi. Maurice, good morning.
Good morning to you.
Welcome to the Situation Room.
Thank you so much.
That's the hot seat of the Situation Room. Make yourself comfortable.
Thank you.
Now, what do you say now on such a day? Happy World TB Day.
Well, we don't really say happy World TB Day. It's just a commemoration of when we discovered the bacteria that causes TB. And probably you can mention it was discovered by somebody called Robert Cox. In other corridors of medical world, you'll hear people saying that patient is suffering from Cox disease. Yes. So we kind of commemorate and we scale up TB activities during this period of World TB Day, and especially the month of March.
Okay.
Yes.
We'll get into that conversation right now because today is World TB Day. C.T. Muga has the day's proverb from a country called
Kenya. You've heard of it? It's on the East African coast. Border Somalia, Ethiopia, Tanzania, Uganda.
Yes,
very arid place.
Yes, exactly. And it also borders the Indian Ocean. Okay. Don't count what they get. Count what they don't get. That's the proverb.
Don't count what they get. Count what they don't get.
Yes, if you are inclined towards counting and you're using that as a point of comparison, then reconfigure your arithmetic process and count what they don't get. Stop looking at what they have. Look at what they don't have. Yes.
They being the other person, not
the people
you.
whom you determine to compare yourself with.
Maurice, what do you make of that proverb?
Don't count what they get. You count what they don't get.
Yeah.
Yes.
Is it that you look for what they don't get so that you get it, or kinda?
You can look at it that way if you wish. This is a proverb. You know, there's a beauty of proverbs. You interpret it as you see fit. Yes. And you can't say that interpretation is wrong. The only time it might be a bit iffy is if you look at what the mouse got and you are the cat, then I'll start asking, so since when did you become a cat watcher and a mouse watcher to start telling us what they got and what they didn't get? So, yes. Beyond that, you're okay. Yes. So what do you think? Now that I've told you you're okay.
Well, it's a food for thought.
You're not okay.
Don't count what they get, count what they don't get.
Yes.
Maurice, you are a TB coordinator for Embakasi. What does that mean?
What that means is that you basically manage or look after TB activities in that sub-county. And sub-county is quite big. Embakasi covers quite a large piece. Actually, most of the easterns is in Embakasi. So in matters of health, we have further divided it into two areas. We have Embakasi East and Embakasi West. So some of the things that we do is ensure that we look out for TB cases. We follow up them on treatment. We ensure that facilities are able to get medications on time. We also ensure that patients receive any other commodities that they may need. And we also ensure that we reach out to even the ones that have not been screened for TB and ensure that they have been screened. And also any other duties that may be assigned by the TB program or the program at the county.
Sounds like the work then begins at the health facility.
Yes.
Look out for reported cases of TB.
Yes.
What do you do before the health facility?
Actually, the health facility is the center of it. Once we get a case, for example, if we are to get more cases coming from a certain region, that advises us to be able to go to that area and screen the people in that locality. Since TB is a communicable disease, and it means that area, specific area where you're getting more cases, then there is a likelihood that the spread is higher as compared to other areas.
Can you give us a recent case where you detected TB in one area and then you went in and found there's actually widespread incidence of TB?
A good example would be in Ruben. I'm sure you are aware about Ruben Mukuru area.
Yes.
There's a facility there that is supported by the faith-based organization. Along the railway line, we got 2 cases. And the people who we treated told us, if the way I'm feeling, you are telling me I have TB, then where I'm coming from, you better come and screen the people that we have along that railway line.
Wow.
And we were able to get 13 more cases in that area. Because TB is a public health concern, it's a communicable disease, and if you look at the socioeconomic status in those areas, if you look at issues of ventilation, if you look at other factors coming in like malnutrition and all that, are more in the areas where TB is found.
Okay.
Yes.
Can we take a couple of steps back? And then just for definitions here, when we're talking about tuberculosis, what exactly is it? We know it's caused by bacteria, etc., but what is it, and how does it affect, or how does it present physiologically?
Oh, okay. When you're talking about TB, of course, it's a bacterial infection and majorly affects the respiratory system, the chest. We'll talk of the lungs in this case. Almost 80% of the cases are actually affect the lungs. And some of the signs and symptoms include the common signs and symptoms that we have around us. An example is a cough. We have night sweats, sweating at night. We have unintended weight draws. We have fever. We have chest pains. We have loss of appetite, general body malaise. All those are some of the examples of the signs and symptoms that are there. And since TB can affect any parts of the body, then we could also have signs and symptoms of other parts of the body associated with the same. For example, if you're suspecting maybe somebody has a TB spine, then they could be having maybe a backache, they could be having some fever, they could also having some night sweats. Probably the cough will not be there, or the chest pain will not be there.
So you can have tuberculosis of other parts of the body, not just the respiratory system.
Yes. So with an exemption, of course, of the non-living parts of the body, the hair, the teeth, and the nails. The ones that you actually, when you can cut and you don't feel
and
any
not feel pain.
Yes.
Is it infectious?
It's infectious.
Okay.
Yes.
How infectious?
Actually, it's quite infectious, because in the areas where we find a TB case, usually there might be a source around there. And as a program, what we usually do is something we call contact tracing. Contact tracing is whereby we get one case and then we're able to find out where could this big case have come from. And for us, for now, we usually go to an extent of the household level. We're able to screen the household, the people in that household. And then in addition to that, if we screen them and they are negative for TB, we give them preventive therapy. Because already we have a known case, so we try to protect them not to get TB further.
So that explains why the folks along the railway line said, look, if I'm feeling like this, then you need to come and check over here, because we've seen others.
We have seen this and this and this.
What does preventive therapy look like?
Preventive therapy is treatment that is offered to protect you from developing the TB disease. And the idea behind it is that we've lived with you and I have been diagnosed with TB. So possibly I've infected you. It's only that your immunity is strong enough such that you cannot get the disease. So to be able to curtail the process of from the infection to the disease, we give you treatment or some medicines that will kill the small bacilli that are there, which you already exposed to before they develop to the disease.
What makes that bacilli thrive?
Well, the bus lights where there is a lot of oxygen, and in the lungs, especially the upper parts of the lungs. Of course, that's mostly medical, and it lights where low socioeconomic areas. So that's why you'll find more in Easterns. We have more cases than compared to other areas.
Pesa.
The idea of low socioeconomic status ama mambo ya poverty kidogo ni vile other things follow low socioeconomic status. For example, you'll find that if it's malnutrition, if you're eating well, of course, if you have good money, you will not be able to, you'll eat well. If you are having good money, you'll also live in a well-ventilated house. You'll not even stay in an overcrowded area. You'll not stay probably in a slum setup. So, and there's a lot of air that is around, surrounding us there.
I just want to ask, because I'm just looking at the numbers here from the health ministry around the caseloads that are reported to hospitals. The respiratory diseases make up around 21% of the caseloads, so roughly 20-something million cases, I think, were reported in 2021. But in that context, can you give us a sense of what the prevalence of TB is like?
Okay. Actually, the bulk of the cases that we usually see in our health facilities are usually respiratory conditions. They account for almost 70%. And if we were to look at the caseloads for TB, in the year 2021, we had 77,854. That is in the year 2021. In the year 2022, the cases went high, as a high of 90,841. And of course, in the year 2022, the cases were a little bit low due to the COVID situation in the country. If you look at Nairobi now here, in the year 2022, we had 12,163 cases. Compared to the year before, we had 10,530. That such that we had an approximate increase of 14%. Out of those cases of last year, around 1,250 were children, accounting for around 10%, which still a little bit on the lower side compared to what we are supposed to get of around 15% of the adults. And we are saying we did a prevalence survey sometimes back in the year 2016. And realized that we are still not getting the actual cases that we are supposed to diagnose. We are missing almost 40% of the cases. So we're still not there. What we mean by that is that the cases we are getting, still there are some other cases that are out there that have not been screened and that have not been diagnosed.
Right.
Yes. And that's why some of the efforts that we are trying to do, for example, this week we are upscaling screening for TB in our health facilities. Like today, for example, in bus station, the whole of this week we have been screening the matatu conductors and drivers. We also conduct outreaches every now and then to be able to try and get as many as possible, because TB is out there, and being a communicable disease spread through the air, anyone is at a risk of getting TB.
A lot of effort is being put into treatment. So screening to catch the infection, and then you're going into, then after you've caught the infection, that's when you go into a community, try and stop its spread and treat those that have been found. How much effort are you putting in preventive and promotive health?
I would say actually efforts are actually almost all the areas are being captured currently. For example, if I can highlight a few issues, we have machines that have come recently that are assisting us in screening. We call them card x-rays. And these ones, everyone who comes to the health facility has to be screened for TB, and then once you have any of the signs and symptoms, then you are sent for the x-ray, or you're sent for a test. We call them gene expert, where you remove a sputum and then it is tested. Then in the areas where we have high numbers of TB cases, we encourage outreaches, and we have support from our partners to be able to carry out outreaches in those areas. In areas where we have few numbers, the activities are not as high as in the areas where we suspect there could be more cases. The idea where we come out strongly after diagnosing a case is because we already have a confirmed case, and we are almost sure there might be a spread somewhere, or there might be a source somewhere. That's why you see we go further to be able to put the people who are in that household on treatment. In addition to that, also through the community health volunteers, in the community health strategy from the Ministry of Health, we are able to give them health education as they continue doing their routine work in the communities to be able to spread the word out there about TB. And in addition to that, we also ensure that all of us get vaccinated. I'm sure we have a mark somewhere for BCG. And also we encourage people to open their windows to allow enough ventilation, avoid overcrowded areas. And of course, once you feel any of the signs and symptoms of TB, you can always come to the health facility.
You see, that's what I was saying. That we have machines that have come, we have all these monitoring protocols in the health facilities, but how much effort is actually being put into going into the communities and saying, open your windows, going to the communities and saying, unless absolutely necessary, avoid crowding, and even defining what does crowding mean. How much effort are you putting to make sure that you do not get even that one case?
Well, I would say the efforts that we are putting in for now is the component of the community health strategy that we are using. We have some few community health volunteers. What we mean by community health volunteers are people from the community that we have trained on matters of TB. In each and health facility, we have 2 or 3 that have been attached to those facilities that are coming from the community. And what we do, at least every 3 months, we ensure that we sensitize them on matters of TB. And as they do their routine work, the routine work means maybe sometimes they visit the household. They are assigned approximately 100 households each. So then they're expected to visit each of the 100 households every month and report each and everything that happens in that facility. So what they do is that they pass out that message about TB. Because the community health strategy also, we have community health units and we have community units attached to this facility. So these community health volunteers have also been sensitized about community TB. So they pass that information there. But as we say, we still have a lot that we can be able to do in that area, because not all areas have been covered by community health volunteers.
You know, whenever one talks about a disease and one that whose prevalence is found in places where the bulk of our population in this country are, or where they find habitation, one has to ask the question of prevention. What do we do to ensure that A, TB is not proliferated? How do we ensure that these people do not get TB? And what can be done? 1. 2, what is being done and how effective is it?
Actually, for what we are doing currently, let's start with the last one. What we are doing currently is that the contact tracing that we are using, we are able to get more cases.
Okay.
And if I can give an example of an area in Madare, Area 4, we were able to do contact tracing for clients for a month, and we were able to get an extra 18 cases out of that. So meaning that it is yielding. However, we still not gotten there whereby we've gotten all the cases. So as much as we are putting in efforts on prevention, we are also putting in efforts on finding out even those cases that we are missing.
Okay, explain this contact tracing and how it's helping you in this particular activity that you're involved in.
So in contact tracing, what we mean is that once we have one TB case, there is a likelihood. For example, for myself, I might have spread it to somebody else, or somebody else might have spread it to me. So I find my contacts, the people that I interact with.
You associate with.
Yes, commonly, and I spend more hours or more time with.
So family, school,
workplaces.
Places of worship, that sort of thing.
Places of worship, still we have not very strong on that, but we do a few cases here and there. But the common ones that we do are usually the schools, we do family, and places of work. And when we do that, of course, we don't pick out who is the exact case, because we also know TB has stigma associated with it, and we also try to avoid discrimination.
Sorry.
No,
go ahead.
Please. Go ahead. Okay, so in It's caused by bacteria.
It's
Then
caused
how
by
come
bacteria.
sometimes there are flare-ups? Okay, are there flare-ups, or is it an illness that just kind of hangs around? Or there's some times where you'll find because of certain conditions, then you'll find that there'll be a flare-up in certain areas, and then it will go back down. Or what then is the situation with that?
For TB, we have not had outbreaks of TB.
Okay.
Well, what happens is that in the areas whereby the prevalence is slightly high, you'll find that all those risk factors are surrounding that area.
Okay.
And the cases are slightly higher as compared to other areas. And those areas where we have slightly higher cases, even when you try to find out, or when you try to do like contact tracing, or when you do an outreach, you obviously have to get, or you obviously get cases from that area. It's also good to note that TB is transmitted through the air, and some modes of transmission is through talking, like we are doing, coughing, sneezing, the common things that happen in an area. That's why we are talking about poorly ventilated area and overcrowding, because you can easily transmit as you talk, as you sing, as you cough.
It's like COVID.
It's like COVID, yes. But the only thing is that COVID also has some service contact. But for TB, service contact does not transmit.
Okay.
Yes.
What I was going to ask is this. Every time we talk about diseases and we talk about some germ or bacteria or virus that causes it, one has to ask origin. What is it that brings this about?
There has to be an infected person.
No. Before the person gets infected.
Before the person
Yes,
gets infected.
this thing that caused the infection,
bacteria.
where is it found and where does it come from before it visits the person and then infects the person?
The known server for TB is a human being.
Okay, what is it in the human being that brings it about?
What you mean is that where did it come from before it came to the human?
Yeah.
Why doesn't it affect cats and it affects humans?
Yes, and why doesn't it affect trees, for instance? I mean, that sort of thing.
Actually, we have some subspecies that affect animals.
Okay.
And sometimes they also affect humans. But for the specific one, Mycobacterium tuberculosis that we are talking about, that one is the main lesseva is the known lesseva is a human being.
So human beings are carriers.
They are, I would call carriers or lessevas, or yes, or
of this
carriers,
of
yes.
this.
Of the bacilli, yes.
At what point does it decide? Okay, so I'm in Rama's body and I don't like him, so let me just. I like him so much. Let me thrive.
Yeah, let me become a disease.
Yes.
It's dependent on someone's immunity. Yeah?
Okay.
It's dependent on someone's immunity, and once the immunity goes down, the bacilli is able to start multiplying in the body, and it's able to cause a disease. Actually, it is said that we all get TB early on in life, and the body is able to contain it in our lungs by formation of some immune response, and so that the multiplication does not happen until when our immunity goes down, and then it is.
So it's constantly watching. It's basically that's in the body, in the lungs, watching at your.
Can stay in the body, in the lungs, and that's where we target when you're giving preventive therapy, so that we clear up that, so that there is no chance of you developing TB disease later on.
Okay, let's take a break. Then we come back and continue the conversation. It's 9:30. This is Kenya's biggest conversation. On this World TB Day, we're having a TB conversation with Maurice Maina, who is the Embakasi Sub-County TB Coordinator. He's here to tell us the work that they've been doing in the sub-county of Embakasi and also in Nairobi as a general, but also countrywide in terms of prevention, promotion, and treatment of TB.
This is the Situation Room, the only way to start your day.
And we still have a TB expert in the house, Maurice Maina, the sub-county coordinator in Embakasi in Nairobi, talking about World TB Day 2023. Rama, before you took a break, you were about to ask Maurice a question.
Yes, I was. Maurice, I vaguely remember very early on in my career as a journalist covering stories around various drug-resistant versions of TB, MDR TB, XDR TB, and we'd see all these horror stories coming out of places like South Africa, dealing with those variants of tuberculosis. Is that a problem for us here?
Yes, thank you for bringing that up. Yeah, we have drug-resistant TB cases in Kenya, and actually we have seen an increase over the years of the drug-resistant TB cases. If I can give an example, for example, in Nairobi last year we had 83 cases, and the 83 cases are spread in amongst the various sub-counties that we have. And what we mean by drug-resistant TB cases is that they are resistant to the first-line drugs. By first-line drugs, we say the basic drugs that we use in treatment of common TB, the TB that we talk about commonly.
Yeah.
So they are not able to treat effectively. So they have to be switched to a more potent or a much higher regimen, and that's what we call drug-resistant TB.
And I know this is varying a little bit out of your remit perhaps, but I look at how as Kenyans we tend to self-medicate a lot. It's I wake up, I'm feeling a bit fluey, have a headache. It's probably malaria. I'll go over to the next pharmacist and buy some random antibiotic.
Yeah.
Exactly, right? that just makes things much worse, doesn't it?
That's very common, actually. Very common in this country, and not just for TB only. Even for many other diseases that we have, and even for TB, it is delaying our efforts to be able to diagnose early enough. Because by the time the people come to our health facility, hata ukiwauliza, they usually tell you kikohozi yangu imeanzia jana ama juzi. But if you take a bit of history, you will realize that it didn't start yesterday or the day before yesterday. They will have gone over the counter, they bought some medicines, and sometimes the medicine they get, some of them are supposed to be prescription only medicines, but you realize that they still get them over the counter, so that exposes them to antimicrobial resistance. So apart from TB being a problem in the bit of resistance, we also have the other issue that is hanging around us about antimicrobial resistance due to misuse. And
that is a growing problem.
That's a growing problem. Actually, it's a global problem. Yes. And for the drug-resistant TB, I think all the prayers that are involved in management of TB also play a part, a little bit apart here and there. But we tend to look more on the patient factors. Poor adherence, maybe they don't take their medications well. Sometimes they don't keep time in taking medications. But also maybe sometimes in the part of the healthcare workers, probably long dosages at times. Sometimes they buy over-the-counter medications that do not treat adequately, so they get exposed. Sometimes lack of knowledge. Not all of us have the same levels of TB information. So sometimes you also get different levels of knowledge, and that also affects our treatment. But we do not have as many cases, but the cases have been on the rise over the years. Yes.
What's the prevalence of infection amongst children? And there's a reason why I ask that. So I guess the next question depends on your answer. What's the prevalence amongst children?
We are expected to diagnose 15% of the adult cases. So what that means is that if we have 150,000 cases, then around 15,000 should be children. Should be, yes.
Okay.
By should be, I mean we are expected to find all the children that are affected, because children do not transmit.
Yes.
So if you find a household that has TB or a child that has TB, possibly there is an adult with TB around there.
Okay. Now, the BCG, in terms of a vaccine, then provides you with some levels of immunity against tuberculosis.
Yes.
Now, there's also the assumption that for the majority of children, whether you're born at a private or even a public facility now, with the immunization drives that we have seen over the last 10 years, is that the likelihood of a child being born has gotten the BCG
vaccine.
Government facility, private facility, doesn't matter. Now, if we are finding that children have this, what is the efficacy of the vaccine then in terms of protection for children?
The vaccine usually assists us or protects us against the severe forms of TB.
Okay.
So if I'm born in a family, I'm given BCG, but there's an adult with TB I'll still get exposed.
Okay.
I'll still at a risk of developing TB, because the vaccine will just protect me in a natural setup where we do not have any TB case in that family. And in most cases, it assists the small children against the severe forms. By the severe forms, I mean TB that is outside the lungs. Could be TB of the lymph nodes, the necks, TB of the spine, TB of the meningitis, such examples. It will protect us from that. We should also not forget the other factors that also come in. We also talk about cough etiquette. If, for example, you are coughing, you protect your child from that. If you are breastfeeding, ensure that you also wear a mask so that you also don't transmit to the children. So basically what we are saying is we will be given BCG, but if there is someone with TB in that family or nearby or in the household, the risk is still there of you getting TB.
How difficult is it to treat? You're talking about, progressive illness here in an adult now, not even for children. But we've heard the stories. And we also know that it is an opportunistic infection as well.
Yes.
So if your immunity is compromised in cases of HIV, for example, the likelihood of you having, and some cancers, likelihood of you then getting tuberculosis and it's sticking around for some time is higher. But why does it seem that it is so difficult to treat, even with the treatment that's available? The cough is progressive, it's persistent, it's there for a very long time. Why is that?
Actually, for treatment, I think is one of the easiest ways that we actually execute very well. Because one of the things that you realize, once you put on treatment, the response is very good.
Okay.
Usually within 2-3 weeks, the signs and symptoms have gone.
Okay.
You are only left to ensure that you take treatment up to the end.
Okay.
And treatment usually takes 6 months. And for the 6 months treatment...
Wait. You're taking medication for this case of tuberculosis for 6 months.
6 months.
TB is nonsensical like that. 6 months, and you're saying that you're
saying it's easy to
you
treat.
sorted it out in the first.
Let him explain why 6
please.
months is easy.
Yeah, please explain why 6 months is easy.
What I'm saying by that is, before you get diagnosed, you'll have been treated for many other respiratory conditions here and there,
and not TB.
Without a solution. So once you put on treatment, within 2 to 3 weeks,
you'll be okay.
The signs and symptoms
Gone.
are gone. And remember, you're also walking in with your healthcare expert, your doctor, because we have to see you every week for the first 2 months. And then after that, we have to see you every 2 weeks. Of course, we're also flexible. If your job requires you away from the health facility for some time, we also allow that. And we also follow up at 2 months, at 5th month, at 6th month. And every time you come, we have to weigh you. Every time we come, we have to talk to you about adherence or how to take your medications. We have to talk to you how to ensure that you complete your medication. We have also to bring in the aspect of you don't finish your medication, there's a likelihood of you getting the resistant.
And that actually was going to be my next question in relation to that, because the tendency that you see among some patients is, but see, I'm feeling better.
I'm feeling better.
So now why am I still taking these meds?
And going to the hospital.
Yeah, what is this? Because now I have to be there every week.
Kwa line, and then I see the doctor. So unasikiaje? Unakunywa dawa? Endelea kunywa dawa.
Yes.
After being on the queue for 4 hours.
So now?
Actually, the 4 hour, being on the queue for a long time, we've actually improved. Even as a public sector, we've actually improved. We're practicing something we call differentiated care. Differentiated care is those who really require to see everyone, they have to queue all along. Those who just need a refill, they bypass some other areas, they just go to the areas of the refill. And sometimes there are some people who do not even need to see any person, anaenda tu anachukua dawa zake, goes home and continues the medication. And we call it patient-centered care. Reason being, not everyone fits in that box. So you have to ensure that everyone is comfortable as they take their medication. And the reason why we really have to talk to them about taking for the 6 months is because we also to ensure that once we treat one case of TB, we have limited the transmission to any other person that is around there. We have also protected other people from the resistant pattern. We have, the resistant strain. We have also minimized chances of relapses. We have also minimized chances of even any other case of TB coming up out of that household that we are talking about.
Is there a very good reason why the treatment needs to be, that dosage has to run for 6 months if you can actually sort out the immediate infection within a shorter time.
One of the reasons why we treat TB for that long is the bacilli, the bacteria is quite resilient, survives in very strong conditions whereby even minimal oxygen it will still survive. And the drugs that we give, we ensure that they stop multiplication, but they also ensure that the ones that are there, we have to kill them. And for the killing them, we have to take quite a bit of a longer time. Of course, there have been trials of shortening the duration, but in Kenya currently, the guidance says you go for 6 months. We have other countries that are doing 4 months. But for us as a country, we are doing 6 months for the normal TB. If we are talking about the drug-resistant TB, then the duration of treatment can extend up to 24 months.
Wow.
And how does one get to the point where you are drug resistant?
For the drug resistant, as I had mentioned earlier, is that one of the easiest ways that you can actually get drug resistant is you given medication and you don't adhere very well, you don't take on time, you don't take the proper dosages, probably you share, or you do as he said, I'm feeling better, do I really need to
stop?
But let me ask this question. Do you offer TB patients adherence counseling?
We do.
Over what period of time?
Well, at the first visit, of course, once you hit by 6 months, it's quite a long duration of time. That is one. Second thing, TB itself has stigma associated with it, so you have to be offered some counseling about that to be reassured that it's treatable and it's curable and you can get well. And then we are seeing them every week. Let's say, for example, it's a case that needs cross attention every week. So part of the thing that we talk about is adherence counseling. Second thing that we also talk about is ensuring that we take their weight, because we also adjust their dosages as the weight increases or if it goes down. And in most cases, they are going to increase weight. That thing that we talk about is also mentioned about the resistance. If we do not do this, then there's a likelihood that this can come, and we do not want to get into this. And that is to the resistant area. So each and every visit that they come, we offer adherence counseling. In some facilities, we also have support groups. We enjoin them so that you also see somebody who has traveled that journey. Started like this, was very sick, and I'm better. So they can actually share amongst themselves.
Okay. Those who living with some kind of immunity compromise, cancer, HIV, is it more difficult then? Oh, okay. Do they get cured if they have an infection like tuberculosis?
Yes, they do.
Okay. They get cured of the tuberculosis.
They get cured of the tuberculosis. As you said, TB is also an opportunistic disease.
Yes.
So you'll find it common in people who have HIV. Though for HIV currently it's very well controlled.
Okay.
So we do not have as many cases of TB in HIV positive clients. There are quite few. In patients with cancer, the cases are there. In patients who inject drugs, the cases are there. In the elderly patients, also the cases are there. And also in people who have poor malnutrition, and people who have not having good nutrition. But the response to treatment is usually superb, very excellent.
Wait, so if you're talking about people, one of the last factors that you mentioned, people with poor nutrition, at the moment, we've been dealing with the worst drought, right, that we've had in like 40 years. You're seeing households right across northeastern Kenya, eastern, down towards the coast, even here in urban areas, right? Household nutrition has really been compromised. So should we then expect a surge in TB cases?
What we mean is that with the nutrition is one of the risk factors of TB. Remember, there has to be an infected person in that area for that to happen. But when you have malnutrition, that is when you're not feeding very well, there is that risk of activation or that risk of developing TB at that point. So in areas that we have TB cases, you'll see an aspect of malnutrition also being there, especially even in children who are nutrition follow-up. You'll find that they are not improving. They are being given some nutrition even facilities, but then they are not really improving because we've still not hit there what is causing this poor nutrition.
When you talk about there being an increase in the caseloads of people who test positive for TB, is it because we have an ever-increasing population, Or is it because the interventions that we have are not as effective as we would like them to be?
Actually, I think the cases why we have an increase in cases, although we are saying we are missing out on the cases, is that we have increased our efforts in regard to screening. And screening is just ensuring that everyone who comes in the facility is asked questions in regards to TB. In addition to that, we have also increased diagnostic mechanisms in our country, ensuring that any person who has any signs and symptoms of TB has been exposed to a test. Could be an X-ray, or a scan, or an ultrasound, or they have been their sputums have been tested. So that has really assisted us in getting quite a number of cases. And then the other thing also, we have moved away from having the typical signs and symptoms. You remember where we bedridden patients, very wasted and not able to do everything. We moved away from that, and now we are looking for TB from everyone who comes into a health facility.
Okay.
Yes.
Sylvia is asking a question. Does the non-active TB come back if treated for the 6 months?
If you are treated, you get cured and you are okay. The only thing that it can come back if there is somebody who infects you again. There is also that risk of reinfection. Remember, if you are living alone and we treat all of us and no risk of exposure, then we are good to go. The risk factor also at the back of our minds has to be there. The reason why we come to a household, we tell you, it's as if you really don't usually open it, or we need to ensure that you look at the areas that you visit, the people that you associate with. Yes.
You're saying we've improved with our diagnostics.
Yes.
So we don't have many cases where somebody is diagnosed with TB after 7 hospital visits and being treated for common cold, for malaria, for malaria hivi.
Actually, that is also one of the areas that as a program we are really looking at. As much as we have improved on diagnostics, we still not gotten whereby everyone who comes to a health facility can be exposed to screening for TB, for example, through an X-ray or something like that. You'll find out, as you're saying, in some cases, a person will have visited 2 or 3 times before they are suspected to have TB. So we still have some of those cases with us. Remember what I said, different knowledge levels?
Yep.
That also comes in
with healthcare workers.
With healthcare workers. But we try as much as possible to ensure that all our frontline healthcare workers have been trained on matters screening for TB, and they are aware of the diagnostic mechanisms that we have as a program.
You know, every time I hear of diseases and the never-ending fight we have, what is sometimes lost is just the effort the government makes. Because every year there is a drive that the government has. Every year. But how do you ensure that this drive achieves the desired results? Let me explain what I mean. What do you do to ensure that everybody knows about what you're going to do? The days you're going to be there, what it is you're going to do, how you're going to do it?
What we do, for example, let me give an example of what we are doing this week.
Yeah.
We are screening the matatu drivers, conductors, and the public in bus station in CBD. So before we start the activity, we have recruited a number of drivers and conductors, a number of the Kanjo Askaris, and told them that we are coming to do screening for the people who are in this area. So we ensure they spread the word out. Then you remember I said about the community health volunteers. We also use them to ensure that the word is out there that we will be screening in the area of bus station for the whole of this week. So that when we station there, we get as many people coming in for screening as much as possible.
Okay.
If, for example, we are going to a community, we ensure that 2 days before the activity, we have the community health volunteers have already spread the word that we are going to be coming to screen for TB. What we do not do is that we do not specifically say he is suffering from TB and that is why we have come here to test you for TB.
Chase people away.
So we target that area. Everyone will run away because of course the stigma associated with that.
Why is there stigma with TB?
Yes?
Why is there stigma?
I think people still have not understood that TB is just like any other disease. And the stigma also comes in because of its association with HIV. You remember sometimes back where if you have TB,
If you had
everyone
TB, you definitely had
yeah,
HIV.
you definitely have HIV. Yeah, that one has really affected us. But we're trying as much as possible to spread the word there that TB is a common disease. It's curable, and everyone can be able to get treatment in all of public health facilities and even private health facilities.
So these are one of those areas where communication on one ended up having some undesired effect on the other. Right?
And also, the stigma with HIV was not the disease, but what was determined as being the common contributor to the disease, its direct relationship to sex. That was the big thing when it came to HIV. So if somebody...
And it was clear it's not actually because you've had sex.
You can
because
explain,
you've had
you
extra
can explain it the way you
curricular.
want. Yes, but
And there is the social aspect of it. How did you go? You must have
Maurice, thank you very much for joining us, and thank you for all the work that you're doing. Maurice Maina, Sub-County TB Coordinator, Embakasi, and also Ramanyang, thank you for joining us today.
Thank you very much for having me back.
Come again soon, like next week, like this.
It's okay. Unless I'm getting you my attention.
Have a lovely day, people.